Değerli konuklar, iyi akşamlar.
Distinguished guests, I would like to welcome you all. This evening we have distinguished international representatives here, and first of all, I would like to remind that it is the National Doctors' Day about in 1919. It is the anniversary of the resistance of students from Faculty of Medicine. Since then, it is a day to commemorate these colleagues, and also it is a resistance to imperialism. COVID-19 has negatively affected the society. Of course, health officers and medical doctors were infected. They lost their lives. And despite all these negative impacts, health officers are working very hard, and of course they deserve appreciations. The Ministry of Health didn't internalize to work with the health organizations and didn't choose to work in the light of scientific approach. If it had been the case, we could have been in a totally different situation, and the health officer situation was totally different. We were all dreaming about a more democratic and a life with equality, and also a life with more protective health measures. In this panel, we will discuss the experience of health officers, which they gained throughout the pandemic, and how we should manage the pandemic and how we should have managed. We have representatives from international organizations, and we will share these issues with you. I would like to commemorate all colleagues from this sector who lost their lives. We will have the following order. We will watch a movie prepared by the assistant medical doctors, and then we will continue with the speech. Yes. Since we have not received the video in advance, we are not able to translate this part. Thank you.
Dediler ki hayat güzel, eğri doğruyu bilenler. Dediler ki umut sürer, insanları seversen eğer. Dediler ki hayat kısa, eğer mutluluklar olmasa. Dediler ki kalmaz yanına yaptıkların bu dünyada. İyiler kazanır, kötülükler kazanır dediler. Mutlu olmak için mutlu etmek yeter dediler. İyiler kazanır, kötülükler kazanır dediler. Mutlu olmak için mutlu etmek yeter dediler.
Mic, please. We would like to thank our colleagues for preparing this video. Let's begin the panel. The first panelist will be our dear colleague Özkan from the Kocaeli Solidarity Academy. She is a nurse in the public health, and she is one of the Academics for Peace supporters. And as a result, she, together with many other academics, she was dismissed from the Kocaeli University, and she has been active in the Kocaeli Kocaeli Solidarity Academy, and she is specialized in occupational health and safety issues. Now we will listen to her, and her topic will be the COVID-19 and the workers' situation. Yes, the floor is yours. Thank you.
Ekranım görünüyor sanırım, değil mi?
I think you can see my screen, right?
Evet, görünüyor.
Yes, we can see.
Teşekkür ederim.
Thank you, dear professor.
Başka teşekkürler de yoldaşım Alexis.
I also would like to thank my dear comrade Alexis and my colleague
Ve sağlıkçı olmayan forumdaki konuşmacılar. Tabii ki bizleri dinleyen
and also all other colleagues. I also would like to thank all the participants.
Ben bugün COVID-19 pandemisinde
And today I will talk about the strikes of the health officers during the pandemic.
Hepimizin bildiği gibi
As we all know,
her sağlık çalışanının sağlıklı ve güvenli
all
çalışma
health
koşulları,
officers have right to work under safe and healthy working conditions and in a similar working atmosphere and working relations. Of course, it is one of the most important achievements that the working class has gained throughout the years. Unfortunately, since the 1970s,
halen devam eden sağlık politikaları,
as a result of the health policies of the patriarchal neoliberal capitalism and also the health systems of this situation and also the unpreparedness of the health system.
sağlık çalışanları
In this respect, health officers may be
ve istenmeyen sonuçlarla
faced such an unprecedented and undeserved
bunu ayrıntıları
circumstances and conditions. Since other panelists will go into details of these issues, I will talk about these negative working conditions and also death. And I will talk about the reaction to these issues, how they did respond to these working conditions. Of course, while I will talk about, there are several options to respond to these issues. And I will focus on the strikes of health officers from 1st of January 2020 to 31st of December 2020, and I will try to answer the following questions. Which countries that we observed these strikes and how long they did endured, and who are the organizers and what are the demands and what are the results? Due to the limited time, I will just present the findings. Maybe we can continue with these discussions upon your questions. On the basis of my research, in this period, while there are COVID-19 cases in 219 countries, I detected 94 strikes in 41 countries. That means 1 out of 5 countries. If you look at the table on the left side, these countries are as follows. And I listed them according to the numbers of the strikes. As you see, the US, as you know, which is a country where we observe the highest numbers of cases. And naturally, we see the highest numbers of strikes. Similarly, India, which is the third country as regards to the numbers of COVID cases, it is the second country in this list. India, together with other countries, 4 or 5 other countries in the world, in India, health officers are facing serious restrictions with their right to make any statement or organizing press conferences. And Malawi is the third country in my list. And when we look at the period, how long did these strikes continue? And these 3 countries, in fact, when we look at this table, there are 3 countries where we see strikes without COVID-19 cases, and these are Sweden, Ireland, and Lesotho. And the rest of the countries experienced strikes after COVID-19 cases were documented. And who are the organizers or participants of these strikes? And the first organizers and participants are nurses, all health officers. Number 2 is nurses, and number 3 is medical doctors. We know that, given the fact that there are nurses and also midwives who occupy the most places in the health sector, it is understandable. And when we look at their workplaces, 91 out of 94 strikes were organized by health officers who work at hospitals, which indicates that, as we all know, in almost all countries, the COVID-19 cases were treated at hospitals. And again, we know that doctors and nurses usually work at hospitals. As regards to the primary health services and first-degree health services, we have just 1 case, and there is 1 strike organized by in isolation centers. And almost 90% of these strikes was organized at local level. That means in one or more than one in one province or in more than one provinces. At 10%, we see that these strikes were organized at the country level, which is important. And regarding the duration, we can say that 1/3 of strikes were organized in the period from October to December, and their conditions were worsened. And as a response to that, there has been an increase in numbers of the strikes. And more than half of these strikes lasted 1 day. Of course, some of them were indefinite, and there are some strikes with 1 week or 15 days. So more than half of them lasted 1 day, and 12 of them lasted 2 days, and there are 3 strikes with 3 days. And their demands, when we look at the demands, and when we analyze the characteristics of these strikes, we can categorize them under 2 main headings. The first one is about the social demands, and we can see these demands in 4 countries: China, Belgium, France, and Canada. They have social demands, and when we look at these social demands, it is lockdown or closing the borders of cities or the country in question, quarantine, and also financing health and social security system. As regards to the demands for health officers, the first four demands, as we can all imagine, is better wage and also additional payments, because it is understood that wage is the first demand, and also providing personal protective equipment, and also working in an atmosphere which is healthy and safety working conditions. And also the fourth demand is that they don't want to see their colleagues dead. And when we look at the results of these strikes, majority of them, maybe half of them, are precautionary. It aims to warn, these strikes aim to warn the public authorities, and 22 of them were organized, yet their demands were not accepted at all. And when we look at 9 of them, half of their demands were accepted. As for 7 of these demands, as a result of the negotiations, or there was a consensus that these demands would be negotiated. So we can say that some of these demands were accepted by authorities, and in some cases, when health officers declared that they would go on strike, some of their demands were met. That means we, as health officers, can achieve our rights through these strikes. As regards to the conclusion and recommendations, according to the literature survey, I clearly observed that, which I knew already, but I confirmed that there has been no change. Systematic monitoring and scanning of these health officers' strikes are not easy, and there is no system to scan and monitor all these strikes. Therefore, monitoring these strikes and also lockouts, and in order to know all these actions, there is need for setting up networks among the trade unions. And all these strikes should be followed by health organizations, health officers, trade unions at the international level and also national level. And there is need for solidarity and support for these type of actions, because in these type of actions, unlike the common assumption, there is no enough solidarity and support from other health officers. In this respect, I think these recommendations are important for this panel and also for my other studies. So solidarity makes you survive as health officers. Thank you.
Thank you very much for this good presentation. And now I would like to pass on to Dr. Otmar Klober. He is the Secretary General of the Medical Union, and he has received his medical training. And following that, he worked in the University of Cologne and Minnesota in the neurological sciences. Dr. Klober, between 1997 to 2002, was the Secretary General of the German Medical Doctors Union. And following that, he was at North Florida University. He was a consultant there. Likewise, in the same university, between 2002 2009 to 2013. He was working in the Health College in the health applications as a clinical professor. And since 2005, he has been the Secretary General of the World Union of the Medical Doctors. And I need to state here that he's a very close friend of the Turkish Union of Medical Doctors, and he has always been our supporter, and we have always seen him beside us. And now the floor is yours, sir.
Thank you very much, Professor Adiaman. It's very kind to have the World Medical Association invited here, and I'm happy to be with you at this event. Let me just say a few words, preliminary words, to understand the context in which we are working. The World Medical Association is an umbrella organization for currently 115 medical associations from around the world. Some of them are trade unions. Some of them, for instance, organize strikes when this is necessary for them. Some of them are associations which are not trade unions, and some are even prohibited to work as trade unions in their country because there is a trade union aside from them which has this role, or there may be no trade union at all. And for some of our colleagues, the idea of having industrial action is still very strange and very alien, just to be clear of that. So when we have prepared for this conference here today, I spoke with Professor Montgomery and the Standing Committee of European Doctors and the World Medical Association, like other regional organizations, have worked very closely together. So I have decided that we will focus for the World Medical Association a little bit on the ethical aspects and the pandemic prepared aspects. Professor Montgomery will have other very practical aspects of the pandemic that are relevant for doctors and doctors' organizations. That does not mean that we are not interested in those, and vice versa. It is just that we have put different focuses on what we are talking today. So I would like to speak first of all about some of the ethical aspects, and there is a long list of ethical problems that have been rising with the COVID-19 pandemic, and I can focus only on a very few, which I think should be very important to this. And you will see it connects to what my previous speakers have said before. Number one is there is this very nice saying by Damien Barr. He said, "We are not in the same boat in this pandemic. We are in the same storm. Some sitting in nice boats, some sitting in very stable boats, others are on life rafts, and some others are just drowning." Inequity is one of the biggest problems which we have facing this pandemic. This is inequity between countries, because there are some rich countries which have better situations to deal with the pandemic, or even have been better prepared for a pandemic, like some of our colleagues in East Asia. But then there are also inequities in the countries, where in some countries these equities are really dramatic, of people who are having a good condition, having a good living condition, can avoid pandemic situations and dangerous situations, and others have to work in very crowded and congested situations every day and can't do that. So inequities are one of the big problems which we face with this pandemic, and I think it is important for the future that we address these inequities. And for us in the healthcare system, I think the inequities are best to be covered or being fought from the point of a healthcare system with universal health coverage. I know this does not cover all the social determinants of health which have to be addressed. There is no doubt about that. But for us as a healthcare organization, we strongly believe that we have support the World Health Organization in the fight for universal health coverage. Some countries are better than others in achieving this and providing universal health coverage, but there is still a long way to go. But we also have to be aware of the differences between the countries. And what we see is, for instance, that there is a huge inequity now with the distribution of vaccine to poorer countries. And that, again, is something that we always have to repeat and have to say that it is utterly important that also poorer countries have access to vaccines. Although I must say, coming from Central Europe, the situation of vaccine supply is a shame in our countries as well right now. But nevertheless, I think the inequities are, for the pandemic, the biggest problem that we can isolate as such. But there have been others. Let me give another example of ethical problems that we have encountered during the pandemic, where we thought a little bit more preparation could have helped us quite a bit. It's, for instance, the triage. And we have seen a number of triage, how should I say, mistakes probably, not by purpose. Certainly nobody wants to do something bad in there, but it showed us very clearly that you have to be prepared for the pandemic, and you have to have a triage system in place, but you have to have it in place before the pandemic comes. And then you may have to fine tune, but it's not that you can start with building a triage system during a pandemic, because then usually it is too late. We have also seen that some of the countries most of the countries have experienced a lot of shortages in healthcare staff. That is especially true in many countries for the nursing staff that has fallen short. And there came ideas about civil conscription of health professionals, of nurses, of doctors, and others. Very interesting question. Whether this is a legitimate way to cope with such a crisis. I think what we have to answer to that is that healthcare systems have to be better prepared for the pandemic. And I will come back to that in a minute. At least I think that civil conscription, except in very limited circumstances, has no place in that. The other area of big ethical problems has to do more with all of us as a society, not necessarily only with medicine, although there are some very specific effects on that. And I'm talking about the limitation of personal rights and personal freedoms during the pandemic, which we have experienced. Isolation, contact reduction, the loss of schooling opportunities for our children, the loss, and that is again very important for many people, the loss of a regular income during the time of the pandemic, a chance to keep your family alive and nourish your family, which has forced for many people to break rules and to break isolation because they have had no other chances. And in healthcare, again, one of the problems that we are dealing with, and I think we have to do much better than we have done up to now, is we have to deal with the questions of privacy. When is there a need to give up a little bit of privacy in order to help to fight the pandemic? And when is it necessary to stay with a very high amount of privacy at, so to speak, any cost for that? Those are questions which, again, we have not really properly found answers to during the pandemic. Last point for the ethical perspective I would like to mention is the use or the abuse of fake news, of fake facts by physicians, by health professionals themselves. Unfortunately, we have seen a real plethora, real avalanche of this nonsense coming through social networks and also fueled by physicians, fueled by other health professionals. I think this is something we have to turn to in the future and have to ask the question, how well have we done in regulating that and also in order to discipline those people? Because I think the freedom of speech has limits. And it certainly has limits when the spreading of fake facts stops people to accept prevention, stops people to seek treatment, stops people to get vaccinations. This is extremely dangerous. And personally, I believe it is not to be combined with our ideas of medical ethics. Some words about the pandemic preparedness. Now, the World Health Organization, as well as the World Medical Association, for the past years, we always have repeated, and at least for the last 15 years, I can say this for the World Medical Association, we have repeated the statement that the next pandemic comes. We have said we don't know what it is, how it will look like, but we have said it comes. And we have also said you have to prepare for this. Unfortunately, what we have seen is we have healthcare systems which more and more turned into commodity business, were commercialized, Some even were put under austerity measures and really had to shrink down to bare necessities. And what we have lost is really our ability to build up surge capacities, to have reserves, to be able to satisfy a very high demand during a pandemic. And this is something where we have been turning the healthcare systems more under the principles of lean production, of just-in-time delivery and production. Well, we have seen in healthcare, it is more about just in case that you are prepared to be able to serve your population. To me, that means quite clearly we have to think about our supply chains, about the structure of our healthcare and healthcare financing, that it can allow a very strong public health service to be able to monitor the situation, but also that it is able to respond to clinical needs when there come surges, when there come real spikes of need, for instance, for intensive care treatment, where a lot of the countries were not able to cope with. So these are things which I think have to change in the future, where we have to discuss with politicians and have make very clear that this must change. Last thing I will just mention, because I know that Professor Montgomery is talking about it a little bit more, the working and living conditions of the health professionals, of the doctors, of the nurses, of all the others in the healthcare systems are something that is of extremely high concern to us. And it's something where we were together with the World Health the World Health Professional Alliance have started to take initiatives in our positive practice environments to work on this and to seek in how we can make or can propose models in order to improve the working conditions. Thank you very much. Back to you.
Duyuyor mu acaba sesim?
Can you hear me now?
Evet hocam.
Tamam.
Yes, we can
Yes,
hear you.
now we can hear you.
Çok teşekkürler Otmar.
Thank you very much, Otmar.
Dediğiniz gibi hepimiz aynı fırtına.
And as you have said, we are all in the same storm. The next speaker will be Professor Dr. Frank Ulrich Montgomery. He is the head of the standing committee of the World Medical Doctors Union, and he was a radiology intern in Sydney. And between up to 2009, he was a member of the Council of the German Medical Doctors Union, and he was also a deputy chair of the standing committee. And since 2019, he has been the chair of the standing committee. Now the floor is to you, sir.
Well, Professor Adyaman, thank you very much for giving me the opportunity to speak to you. If I may just say something about the first presentation and the mentioning of strikes. The one thing you didn't mention is I was head of the German Trade Union of Hospital Doctors between 1989 until 2007. This was the time when the German doctors experienced their liberty and through strikes got better working conditions and more wages. But this is just a preliminary, because I was quite surprised when I heard in the first presentation that you were mentioning strikes in the present time. And I would like to say that with the experience of the European medical associations, I have not encountered real big strikes in the last year, because through all the austerity measures that Ottmar Kloiber already mentioned, through the downsizing of healthcare systems in many countries of the European Union, we could not strike because we simply had the ethical dilemma that we had to see and treat our patients. We could not strike because otherwise our patients would have been left uncared for, and that was an impossible situation for us. I have three basic points which I would like to mention. One is a short overview of how countries ran into the pandemic. The second is what were our key concerns. And the third is what are the lessons which we can learn from this pandemic. Let me start with a slight overview of the totally different situation, how countries got into this pandemic. There was countries who were totally unprepared. For instance, in the region which I can overlook in Europe, this was, for instance, Italy. Italy had about 4,700 intensive care beds for 60 million population. And they had simply not considered that a pandemic this size would run over the country. And you all remember that in February 2020, only 13 months ago, they had experienced the first lockdowns and the first dying healthcare officers, healthcare professionals, which was a real threat which showed us how difficult the situation was. The opposite side was, for instance, the German healthcare system, which had approximately 27,000 intensive care beds for 80 million population. This is about 4 times as much as Italy had. We were very well prepared in the first wave. I say we because I live in Germany, sorry. But we were very well prepared for this pandemic. And in the first wave of the pandemic, Germany behaved very, very well and had a very good result. It's a lot of issues to discuss whether we don't run into this prevention paradoxon that people don't realize how dangerous something is if it is treated so well. So people didn't believe any longer that COVID was the threat it really is. And this is why we ran into a really devastating second wave in these countries as well. Of course, you all know we had very ignorant countries, like, for instance, the UK, the US, or Brazil, where governments, where state leaders didn't believe in the virus really being a problem, and they took a very, very heavy toll, a death toll on the whole disease. And then there were faulty countries, like, for instance, Sweden, who believed that they would achieve herd immunity in very short time. We know now that this was a mistake as well. And we have to say some of the countries that fared best were the very authoritative countries, like, for instance, China, Taiwan, or South Korea, where through strict government measures, the death toll at least, and the heavy toll on the heavy burden of disease on the country was not as heavy, if the statistics are right. This is always a small thing we have to think about, as in other countries. So we have to see, and I very much liked the quotation by Ottmar Kläuber of boat and storm. Indeed, we are all in the same storm, but we ride totally different boats. And sometimes we have the feeling we are not only riding the boat, we are also rowing it. And this can be a very, very heavy experience. Now, what did we encounter in Europe? First of all, there was a strategic shortage of medicines, of supplies of every time. I myself, during my presidency of the German Medical Association, was involved in the German pandemic plans. And when we made the pandemia plans, we thought that we would get every supplies, masks, gowns, whatever, within a week from China. And our whole pandemic plan was based on just-in-time concepts, and we had to learn very, very heavily that this was wrong. The planes didn't take off in Wuhan, bringing us gloves and masks, etc. There was shortage of medicines because some medicines are only produced in 1 or 2 countries of the world. And if 1 or 2 of these factories burn down, then suddenly there is a real shortage of medicines worldwide. Personal protective equipment was one of the very big problems of the first wave. This is gone by now, but we had to learn from it. We have to come from a just-in-time concept to a just-in-case concept where we are prepared even for these shortages and these globalization problems which we encounter there. The second was workforce. In many countries of the European Union, the workforce has been run down heavily due to austerity measures. I think Ottmar mentioned this already. And we had a problem filling our ranks again, because doctors were not only treating COVID patients, they were COVID patients themselves, and they couldn't treat others. So in many countries, we had to organize getting retired physicians or getting retired nurses to go back into their former jobs and help treating and caring for the sick. And we even had to fast track students and specialists, highly qualified specialists like radiologists suddenly had to do intensive care unit work because we were simply short of physicians and nurses and all the other healthcare professionals that help us treat our patients. And we encountered some very heavy burden on the psychosocial and mental situation of our physicians. The death toll amongst physicians and nurses was high. And this is why we finally, together with the Italian doctors' organizations, the FINOMTEO, unveiled a plaque of commemoration for all the healthcare professionals that succumbed to this disease and that died in the first year at the hospital in Cordogno, where on the 20th of February last year, the first physician died of COVID-19. Now, finally, we have to talk about a very special system, and that is the European Union. Ottmar already mentioned that some of the countries in Europe don't fare well with the vaccination program, and this is true. The European Union, and I'm not trying to be unfair, I simply said they made a lot of mistakes, but they also did not have the competency, because the member states in the European Union always demanded the running of the social care system in a country is a member states' affair. So it was unfair to the European Union, but we have to talk about a European health union now. We have to rediscuss all these positions. Now let me come to four final things which we have to learn, which we had learned about that. First of all, we do need international pandemic plans. The virus doesn't respect borders. The virus doesn't know borders. And we have to have international pandemic plans who are integrated into each other, who work together and who join forces in combating this disease. Secondly, we have to rediscuss national reserves. And I think on a European Union level, this would be European reserves, but every country has to consider what is the basic equipment and basic medicines which have to be available in the country, even for longer periods of lockdowns, of broken supply chains, whatever. This comes a little bit into the old system of, and this is my third point, of autarky. I think we have to consider again more national or European-wide or cooperations and keep our forces together. And finally, and I think this is a very broad aspect, we have to rediscuss globalization. And there is this wonderful saying of we have to come from a just-in-time concept to a just-in-case concept. We have to be prepared, because if there is one thing sure in this world, we're not sure when are we going to win over the COVID pandemic, but there is one thing sure: the next pandemic, be it viral, be it bacterial, is already around the corner. So we have to prepare for the next pandemics, and this is why symposia like these are so important, because we can exchange our experiences and try to be better prepared for the next pandemic. Thank you very much, Professor Adiaman, and yes, thank you for giving me the word.
Çok teşekkürler Profesör
Thank you, Professor Montgomery. The next panelist is Dr. Alexis Panos. He is an emeritus professor, and he worked at Thessaloniki University, and his main interesting areas are social determination in health, and also social epidemiology, and also basic health services. And he is a long member of the International Health Services and also one of the founding members of the People's Right. Yes, the floor is yours. Floor is yours, Dr. Benos.
Teşekkürler.
Thank you.
Thank you very much. Thank you for the honor to invite me, because for us, and I'm speaking as an international level, the Turkish Medical Association is really a showcase for us physicians in all the world, because I'm speaking from my own country, of course. Unfortunately, for example, the Greek Medical Association is not so open-minded. It's very directed only to the short interests of its members, which actually during the pandemic was not very good, as possibly I will say if I have time. Anyway, so now the pandemic is a global, as it was said by the other colleagues, of course, it is a global issue, a global threat, which needs, of course, a global or internationalist response. So what happened? I'm going to put two points mainly. The first point is regarding the response of the public health services. Globally, and of course in Europe and even in my country also. What happened is that, unfortunately, due to the decades of austerity policies, all in globally, we have all the public health services dismantled, unorganized, without health professionals, health personnel. I think besides our countries, for example, my country is a case like that, but I think much more important example is, for example, the CDC. You know that the Trump administration, when they took over, Trump diminished by 50% the funding of the CDC, and that's why they had problems in organizing the monitoring and so on. Another awful example is the UK, in Britain, where as people like me, in public health, UK was, a light in our, even we were going there to learn about public health. And unfortunately, today, as we saw in the pandemic, the British government made outsourcing in private sector, even monitoring and testing. I mean, so that's why they could not have an efficient monitoring and understanding of what is happening in the pandemic. So this is global, unfortunately, and it is neoliberalism all these years after the 80s, which is regression of the welfare state. And so why do we need public health services? And here is the pandemic, which is coming and showing us bluntly, I think, and with a lot, unfortunately, of victims, that yes, we need public health services. Because if we had good, efficient and open-minded public health services, then we could have early monitoring, we could much more earlier understand how the virus is expanding, what is the expanding and the epidemiological virtue of all the pandemic, and of course take much more easily and quickly measures. What is happening is that we are not taking measures, and actually, and I'm going to speak about my country, for example, Greece, the government is doing nothing in controlling the virus, the expansion, but to make, as we call it, off and on lockdowns. So when, for example, now we are just this week, we got back to all national lockdown, because again, we had a third wave, which is going on very dramatically, actually. So because no measures were done, and of course, no measures where the problem is. And this we have to say, and it was said before, I think, by Frank, or by Otmar, I don't remember. Anyway, we have the problem globally is that even in the beginning, the epidemic, the pandemic showed that as being a problem of businessmen between China, Italy, Spain, UK and the United States. Today we know, and there are a lot of data globally in the literature, that this epidemic, also pandemic, is hitting the lower social classes, so is growing the inequalities. So this and that has to do also with the lack of public health measures, because we know that the main, for example, here now we have lockdown, but the workers are going to the work. So they're going packed in buses and metro, and they're going in work conditions packed again, so without any measures. And of course, the epidemic is going on. So all this example, and I think it's global, it's international, is showing the need to have good public health services with a lot of people, and professionals all around the country, in order to make a good surveillance system, in order to understand what is happening. As, of course, as Frank, I think, said also, that it's not this virus also only. We are expecting others, and we're expecting a lot of others, because of the way that the agro-business industry is working. And this is another issue that I'm going to speak in closing. So the first issue is that we understood that public health services are not working, public health services. Then the other point is regarding the public health services care, which are mainly the hospitals, which had all the burden, the original, the unspoken and unprecedented burden of disease, of morbidity, and of course of mortality. Here we had really, as it was said also, our colleagues, all health professionals, that really was shocked, first of all, was afraid because of the danger, even for their own safety. There were no, in the beginning, if you remember, globally, we didn't have even personal protection equipments. Huh? And there also we had nationalism, who is going to buy and who is going to pick the planes and things like that, which is proving that we are not in a very good, as humanity, in a very cooperating mode these days. So our colleagues, professionals in the system, worked under very stressful conditions, of course, and trying to help people to avoid death, actually. And that's why we have a lot of psychosocial burden also in our colleagues, beside the death and morbidity, of course, in all health professionals. Here again, we have to go a step backwards and see that the pandemic came in, and the health services already were dismantled, destroyed, actually, in a global level, I repeat, because of the austerity and the neoliberal policies imposed from the 80s, and actually from the 2010, even in Europe, are much more aggressive than before. So our systems were, for example, in Greece, we have the lack of personnel, lack of intensive care unit beds. We have one of the lowest in Europe. Our personnel also is getting old, because there are no newcomers. They are not putting new people with salaries in the system. So this system was asked to answer to the problem. And they are doing the best they can, of course, but burned out, deceived, and seeing that there is no any solidarity from the governments. There is no any move to put new people there, and so on and so on. Another issue here, which has to do with the private sector, is that in Greece, at least, the private sector is COVID-19 free or sterile. So they are not accepting any COVID. And the government, instead of pushing them or even making severe decisions to use all the facilities of the private sector, what they are doing is just to they are giving them more public funds in order to help them deal with the other morbidity. Here also a small note I want to make is that not only Greece, but in Greece certainly, but all over the world, the health services, the public health services, are taking all the burden of COVID, and they are closing down the services for other diseases. So we have a neglection, a new wave of neglection of the other diseases, and we have an excess mortality, which is not only due to COVID, but mainly it's to non-COVID cases, because there are no services to respond to the needs of people with cancer, with diabetes, and so on and so on. So this is the setting globally, I think. And from the beginning, when we started, we thought, I mean, I think a lot of people, probably all of us who are speaking here, that the pandemic was a good example for all our governors globally to see, okay, we know you think that profit is better and so on, but we see today that we need public health services, both as public health, epidemiology and so on, and both as hospital and so on. So it's a good opportunity for us, we thought, that the policies are going to change and the public health systems are going to be enforced by funding, by personnel, and so on and so on. Unfortunately, as it seems today, the pandemic is not only did not change the minds of our rulers, but in the opposite, they are using the pandemic as an opportunity to make a bigger and bigger in growth private sector instead of the public sector. So this is, of course, recycling the problem. And we are today, globally, I think, I'm sure about that, globally we are in a situation that the crisis is getting bigger, the inequalities are growing because COVID also has a very specific class point. I mean, the lower classes have the big burden of the disease. And as also it was said, because of the lockdowns, we have the growing of all the social determinants of health, which are wealth, salaries, poverty, food, and so on, which are deteriorating in a very big scale and quick scale. And this is going to be seen. Nowadays, we haven't seen it yet because we are under the pandemic. But when the things are going to be better regarding the pandemic, then we're going to have the economic and social pandemic, which possibly would be even worse than the clinical pandemic. So, concluding, in my view, what we have here is a good opportunity to understand that we have to change, and we have to change everything in the leading system, I mean, in capitalism. Because, first of all, we have to see the causes of these pandemics, not only this one, but the previous SARS and so on, MERS and so on, which are all related with the agribusiness profit-making intensity, okay? So how the agribusiness, especially the meat business, is producing meat, and this is producing and reproducing new viruses and so on. So instead of only thinking how we are going to deal with the new pandemic, we have also to take steps to prevent a new pandemic, so to change the agrobusiness. And then, of course, we have to see what it was also said, to prepare, so to make public health services better, to make a universal health care system. Here, I want to tell you only one issue, because as I am from Greece and the association is from Turkey, which is a recent issue. I mean, the Greek government is saying that, they're saying officially that when we are asking them to reinforce the public health system, they are saying, okay, the pandemic is here today, tomorrow it's going to pass. So why to reinforce a system? And then we're going to have a system which is very well done, but without pandemic, with a theoretical no more danger. And the answer of me and of us, a lot of people, is that, okay, in the same way, there is a theoretical danger of war with Turkey. So that's why you are buying, and this is a recent issue, they bought new fighters, airplanes for war, and they paid billions of euros, and they cannot give just some millions of euros to the healthcare system. So this is also a choice of the system, and we have to, as physicians and as health professionals, we have to fight against that also. And finally, because now we are living the problem of vaccines worldwide, I think this is another issue also. I'm afraid that I am much more pessimistic about the European Union than Frank. I mean, I think the European Union showed that it is a union for the profit, but when it's coming for the health of their populations, there is a nationalism now. All countries are making their own deals to have some more vaccines than the others, and so on and so on. It's a vaccine war. And all this, of course, is because the vaccines, as the drugs also, are not considered as goods for the health of the people, but are as goods for profit making. So I think it is, and it's really very important, and I'm glad that already there is a movement globally and in Europe that we have to speak about patents, and we have to stop that. We have to go back and see that we can manage it and we can have drugs as a social good, not under the profit-making rules, but under the rules of the needs of the population. Thank you.
Doktor Benos, çok teşekkürler bu çok
Dr.
doyurucu.
Benos, thank you very much for this very fulfilling and satisfactory presentation. Now, the next speaker is Anita Kennedy, and she is the chair of the International Council of Nurses. This is actually a federation of 136 such unions, and is representing more than 20 million nurses all around the world. It's being managed by the nurses, and as a leader of the nursing profession, and keeping the quality, but they're also continuing to work as the voice of the health policies. Madame Anita Kennedy was also the chair of the European Confederation, and in 2017 she was selected as the 28th chair. Now the floor is yours, madam.
Your phone is closed, I guess.
Apologies. Can you hear me now?
Yes.
Thank you. Thank you. Thank you to the Turkish Medical Association for inviting me to speak today. And I have to say that I agree with the previous speakers. There's nothing that I would disagree in what you have said. It's extraordinary that, you know, today, in a day when we have extraordinary advances in technology and extraordinary advances in science and in extraordinary advances in space, and yet the whole world came to its knees with a virus. It's unbelievable that both the countries, the world, and our economy came to its knees with a virus. And as the independent panel for COVID-19 said, the world was not prepared. We have to do better. Just a little bit about my association, which is very like the comments that Ottmar made. It's a combination of unions, of regulatory bodies, and of associations, and quite a mix of those. It's also one of our great leaders was Florence Nightingale, whom is well known in Turkey, and the Salima Barracks have a museum there to her. But her great, I suppose, interest and her great asset to health was in relation to prevention, infection control, and data collection. And I don't think that she would be out of place today, which is extraordinary, 150 years later. We celebrated 200th of her birth last year. We were to celebrate, we didn't. But so to go to some reflections on the pandemic from, I suppose, a global nursing perspective. Our priorities were about in relation to universal healthcare. They were into in CDs, the Sustainable Development Goals, and working right across with the World Health Organization, the UN, the International Labour Organization, the Red Cross, and many more, and many of our professional organizations, including the World Medical Association. And it was all about improving the conditions for nurses, being the global voice of nurses, and protecting nurses, and having improving things so that there would be better conditions for the patient. That was what we were all about. But that changed dramatically with COVID. And instead, it made us work very closely with all our associations. So from the very start, from January, when we started hearing from China and from the Asian countries, we started sharing information. And that was probably the best positive aspect that came about, because all their issues and problems and how they sorted out their problems was coming to us very clearly and very fast. And so that we started sharing them across the world. Unfortunately, I don't think the world took anything seriously until we saw what was happening in Italy and Spain. But then we started sharing the information from Italy and Spain with Latin America and with Africa and with our colleagues in other countries. And it was always a cross between backwards and forwards. But like everybody else said, the main issues for us were, we went into this pandemic with a shortage. We went into it with a shortage of 6 million nurses, and that's WHO confirmation from a report that was done last year. Now we are seeing from our own research that the nurses who are at the end of their career are mostly in Europe and North America. And we estimate that 4 million nurses will retire within the next and less than the next decade. That in turn is about 10 million nurses. Added to that, we're hearing from all our associations throughout the world that many nurses are leaving because of their experience with COVID, because of the post-traumatic stress disorder, because of anxiety, because of depression, because of the violence that has been perpetrated against them. And as you know, 90% of nurses are women. So this has been very difficult for them. And the high-income countries and the low-income countries and the middle-income countries are very different. So when we say there's a shortage of 6 million, we're talking about 80% of that is in the low and middle-income countries. So they have fared very badly in all of this. Added to that, the lack of PPEs in all countries was a major issue for us, and we have been lobbying at global level and at national level for that, but it has been worse in low and middle income countries, and it still continues to be an issue for those countries. So, and I heard somebody say earlier that about striking, there has been, and I agree with what has been said, the nurses couldn't strike during the pandemic, but there were countries in Africa who were not getting paid, who were not getting any kind of protection, and they had to strike. They had no option but to strike. And that does not come easily to nurses or any health professional, particularly at a time of a pandemic. But the other thing that's happened and is very concerning, and it should never happen again, and that is that between 1% and 30% of nurses, healthcare workers, but mainly nurses because they take up 60% of the healthcare population, became infected with COVID. We're estimating that probably 1.6 million are infected. We know that's an underestimate. We know that currently, out of 57 countries, 3,000 nurses have died. Amnesty International says that 17,000 healthcare workers have died. Even if you take 1% of the total number of people that have died, which is over 2.5 million, then you're talking about thousands of nurses and healthcare workers that have died. This can never happen again. We went in unprepared. We didn't, as many people have said, we didn't have the health systems. We didn't have a strategy. There are only a few countries, I think, that came up well out of this. And I will say this because of our, I suppose, association with Taiwan. Very clearly, very quickly, Taiwan started giving us information about what they were doing. And they closed down very rapidly. They started testing, tracing, and of course, they wear masks. They were even sending us in the office masks, I think probably in February. So they were doing things because they had a strategy from SARS. They had a strategy that they could open emergency beds, that they could do certain things, that they had the legislation was already there. So they went in very fast. Another country that's fascinating is Mongolia, which is between Russia and China. And they did very well because they closed down fast too. Now they're an extremely poor country and a small country, but we have to look at some of those countries and see why did they do better and why did we in high income countries do so badly? Because we can say that no country came out of this well, and particularly the high income countries did not come out of it well. The other thing, that the mental health issues of not just healthcare workers, but healthcare workers, because they're so close to COVID, have fared very badly. But mental health throughout the whole world has fared very badly. And I think that we will be looking at that as a major issue into the future. And as already has been said, we had to focus mainly on COVID, probably on emergency medicine and obstetrics, and all of the other healthcare issues got put aside. So by the time they come to the fore, by the time they come back in, they will have multiple complications. And that will require more activity, more resources. And I think for us, as a collaborative effort between multidisciplinary teams, we have to look for better with our governments. And some of the things that's already been said, public health. Public health has not been done well in any country throughout the world. Money has been taken from primary care and public health and put into hospital care and specialization and research. We have to look at different systems of healthcare. There's no doubt in my mind that we have to change it, and it has to be a change from healthcare treatment to prevention. And we are not, I don't know that any country is doing well in prevention, early intervention. We have to have public health data. One of the issues that we raised very early on was the data collection. As I said, between 1% and 30% of healthcare workers will become infected. Now we are seeing that we had asked several times for data, standardized data to be collected across the world. It wasn't being standardized, and what was happening was that we were getting collective data on healthcare workers, not on individual groups of healthcare workers, or not on tracking and tracing. And now in my own country, what I see is the healthcare workers have been vaccinated. Well, the infection rate has gone way down, way down. It's nearly at 1% or 0. That is unbelievable. We have to have equity, has already been said, in vaccination, because the inequities between countries and in country is obviously, it's been highlighted through COVID. But equity in vaccination is an interesting concept because, of course, countries that have more money will be buying in but who is pressurizing the governments to do that? It's society, actually, that's pressurizing them. We are not saying as a society and as individuals, and I put myself in there, we are not saying, yes, the people that are in the front line, like the healthcare workers and like the people who are suffering conditions like the older population who are the most at risk, should be vaccinated all over the world. And that we all as a society agree to that before everybody else is vaccinated. So I think sometimes we have to ask the serious questions about this. The other thing that I think we have to do is that we have to talk about e-health. One of the things that has done very well is the use of IT. You know, we never thought that we could talk to patients, do a lot of communications on the telephone or through applications or through different media. We didn't think that we could have a lot of these conferences this way. But I think that we have to look at artificial intelligence and e-health and technology in a very different way. And not alone that, but I think that it has to be professionals, health professionals that have to be involved in the development of all this technology. Otherwise, it won't work for the people. We have to bring health closer to the population, closer, not be constantly bringing them into hospitals. There is probably no need in a lot of cases to be bringing them into hospitals, to bringing them into GP surgery. We can bring things closer to them. We have to look for investment. And my big concern is that billions have been poured into curbing the pandemic and trying to save the economies. Well, that money has been borrowed. My concern is that there will be a clawback on that money, and I'm not sure that we will see investment unless we're very strong in healthcare where it's needed. Because without healthy people, you don't have a healthy economy. But I'm not sure that governments have taken on that on board yet. So it's up to us. And interestingly enough, a medical practitioner working in the NHS for years wrote a book, Can Medicine Be Cured? But one of the things, I'm going to finish now, one of the things he said was that nothing would change in the health service or in medicine until we had a pandemic or until the economy went down. And he wrote that book in 2019. I don't think that he was predicting what would happen, but that's it. Thank you very much.
Çok teşekkürler Anetta Kennedy.
Thank you very much for your very nice presentation, Madam Kennedy. Now, the next speaker is Mr. Owen Tudor, and he's from the International Trade Unions Confederation, and he's the Deputy Secretary General. And he's in the Oxford University, and he's actually been trained in economy and philosophy, and he is a member of the board of editors of the publication of the Labour Party, and he has been actually selected as a senior manager and is managing the European Union and international relations. Mr. Tudor, the floor is yours.
Well, thanks very much indeed, Sinan. And the problem, of course, of going last in a list of distinguished speakers is that everyone has already said everything. But where I repeat what they say, it should be taken as reinforcement of their points. I'm honoured to join your discussions to speak about the year just passed since the World Health Organization confirmed that COVID-19 was a global pandemic, and on the Turkish Medical Day. I represent 200 million trade union members from 163 countries and territories worldwide, and I will therefore go wider than health professionals in my remarks. I want to pay tribute first to all those who have died or suffered from this pandemic, and in particular to 4 groups of working people. First, those workers in the health and care sectors who've put their lives on the line to care and protect for others. Doctors, nurses, other medical professions, but also porters, cleaners, care workers in care homes and in the community. Many have lost their lives, faced terrible working conditions and hours, the stress of seeing patients and colleagues suffer and die, sometimes separated from their families because they were shielding them. Second, the workers in so many other lines of work whose low levels of pay and insecure working contracts suggest that they're not as valued by the people who run our politics or our economies as they have in fact turned out to be during the pandemic. Food workers and shop workers, delivery drivers, transport workers, educators, and many others. They put their lives on the line to make sure we could live ours. Third, I pay tribute to the scientists and technicians who researched and developed the tests, vaccines, and treatments that will allow us to return to normal lives. On the subject of those tests, vaccines, and treatments, we do, as other people said, need now to ensure vaccines for all and an end to vaccine nationalism. As the Director General of the World Health Organization puts it, to the vaccine, we are one herd, and no one is safe until everyone is safe. From a movement founded on the maxim that an injury to one is an injury to all, I recognize and support that sentiment. Next month, on World Health Day, 7th of April, the global trade union movement will call for vaccines, tests, and treatments for everyone, which will require more funding from rich countries for manufacturing and health services, and a TRIPS waiver to prevent the monopoly of vaccine information that Big Pharma has established on the back of public taxpayer funding of research and rollout. And the fourth group is my very own line of work, the trade unions that have stood up for workers' jobs in the health sector and in others, for their livelihoods and rights in the pandemic. Union safety representatives in the workplace who have negotiators dealing with employers and governments who have demonstrated as never before that we have workers' backs when it comes to a crisis. As we emerge eventually from the pandemic, we will still be needed as more than ever, and I will return to the work we will need to do to ensure a fair recovery and resilience are achieved. But before that, I want to identify some of the lessons we have already learned from the pandemic. As many people have said already, we were fundamentally and fatally not ready for a pandemic we knew would come. As others have also said, health services had been cut to the bone by decades of austerity and by the pernicious belief that markets know best, a key reason why my own country, Great Britain, has fared so badly. Safety at the workplace had been attacked by deregulation and anti-union governments, employers who put profit before people, and complacency at all levels. Weakened unions and workplace rights mean workers have not felt confident to refuse to work in dangerous circumstances, something they have a legal and human right to do, although many have struck, as Özlem reminded us at the beginning. Workers had been forced into insecure contracts, dangerous working conditions, poor provision and low wages, and above all, especially in the informal sector, inadequate sick pay, so that when the pandemic struck, many workers were forced to choose between spreading infections to their workmates, their customers, their communities and their families, or putting food on their family's table. Unions were already under attack before the pandemic, and too many governments have disgracefully taken advantage of the pandemic to redouble this. This toxic mix led to workers left exposed without adequate personal protective equipment, unable to take time off, with scarce hospital beds and of course, unsafe workplaces, weakened unions have not just been bad for workers. Those workplaces include hospitals, old people's homes, restaurants, buses and trains. A study of New York nursing homes in one of the richest parts of the planet found that where unions weren't present, infection rates for the residents were 30% higher than in unionized old people's homes. So what do we need to do to promote recovery and resilience? The ILO estimates that 255 million jobs have been lost to the pandemic, and 1.6 billion people in the informal sector have lost income as a result of it. So we need a new social contract. We need more and better jobs and greater investment in the care economy. We need greener jobs that don't take the planet for granted, maybe something at the root of the pandemic, as Alexis hinted earlier. And we need better paid jobs with adequate living minimum wages for all. We need stronger rights at the workplace, covering all workers, not just permanent employees, and including making occupational health and safety a fundamental right at work at the International Labour Organization. That will be the theme of Workers' Memorial Day on the 28th of April, and we will also renew our calls for COVID-19 to be recognized as an occupational disease, and for a biological hazards convention originally proposed at global level by trade unions 20 years ago, and that would, together with learning the lessons of SARS and MERS, have prepared us for this pandemic. We need more efforts to achieve equality, as Otmar mentioned, recognizing that poverty promotes illness and vulnerability, but also that women and Black people have suffered more than most during the pandemic, including a nasty surge of domestic violence, especially for those locked down with their abusers. We need universal social protection and universal health coverage, starting with a global fund for social protection that would help countries ensure proper sick pay and decent quality public health services. And finally, we need a more inclusive society based on peace and democracy, with better provision for young and old and fairer taxes to fund it. This new social contract will create a world more secure and resilient to economic, environmental, and pandemic shocks. It will create a better, healthier world. Thank you for listening.
Sayın Owen,
We would like to thank Mr. Oliver Tudun. You keep your words lifted us, and we feel more motivated. We feel better. We have some questions. First of all, there is a question that goes to all panelists. In Turkey, there are numerous inequalities as regards to the allocation of medical doctors and appointment of medical doctors to the COVID-19 services. What is the situation in your country? What is the criteria for assignment of medical doctors to such services? Of course, as in the case of other countries, faculty of medicines have been negatively affected and immensely affected. What is the situation in your country? So the floor is yours, Dr. Otmar.
Thank you. I cannot speak to a specific country because the World Medical Association now has quite a broad base with that. And I'm certainly most aware of the situation which we have in Central Europe. And there the situation was, I would say, very fortunate for all of us, because we have very established services taking care of mildly sick people in the primary care service, which I think the family physicians have done excellently. And then in the hospital, intermediate care for those who come in with symptoms which have to be treated stationary, but not necessarily need intensive care and intensive care. But what we also have seen is that we have had a shortage as well of personnel as of technology in those countries which have suffered from austerity. And this is especially the countries in the south of the European Union, which really have been, where the healthcare systems have been gagged over years and have been reduced to a bare minimum. And that, of course, is a real problem. Otherwise, I think that for those parts of the world, for this part of the world, what I've seen is that the major deficit has been there with the nursing care, because there has not been put enough effort in having optimal working conditions and payment conditions for nurses. And for all of us, it's true that the problems which occurred with the big stress with COVID-19, regardless whether that is in Europe or in Latin America or the US. There have been no services really to cope with this in order to help the staff, in order to help people to cope with those problems in there. And these are also learnings of shortcomings which we have had. Maybe that Monty wants to speak about that, but I didn't see that there were too many problems in allocating physicians to the services. That has worked quite smoothly. There was an attempt actually in my home state in North Rhine-Westphalia in Germany, where the government drafted a law to conscribe doctors in order to treat COVID-19 patients. But then it turned out this is absolutely not the problem. The problem is rather that we have to have enough places, and that we have to have nursing care, and that we have to have now, for instance, enough vaccines in order to prevent the further spread of the disease, but not the workforce itself there, at least not the physician workforce. Back to you.
Çok teşekkürler.
Thank you. Dr. Montgomery, would you like to respond to this question?
Yes, I can only emphasize and endorse what Ottmar has said. In Central Europe, at least, we did not have a problem with the medical workforce. We had to reallocate some people, but we had sufficient physicians. We also had sufficient nurses in most countries. I cannot speak of every country. I have heard about of problems in Italy, but that happened. That was due to the unpreparedness at the very beginning, and it improved over time. But however, those who worked and who did their services to the patients suffered a lot from burnout to mental problems. For instance, just a simple figure, in ICU care, normally an ordinary patient lies in an ICU for about 4 to 5 days. And a COVID patient, the average length of stay in an ICU in Germany is over 18 days, and the mortality rate is over 25%. This puts a tremendous stress on the personnel looking after these patients. If you really fight for the life of a patient for 18 days and still lose for a simple little thing like this virus, that is a tremendous mental stress for the people working on ICUs. And I think this is even the greater stress for nurses and other healthcare professionals than for the physicians. So, but, you know, we are all talking of the past. We don't know what happens in the future. And in Central Europe, just now, the third wave is beginning with a very high speed. And I think we'll be in a much more difficult situation pretty soon.
Çok teşekkürler.
Thank you, Dr. Montgomery. Anetta, you are representing the union of nurses, which have nurses from hundreds of countries. So would you like to respond to this question as regards to the nurses, of course?
Yes, and I suppose in every country there is a shortage, but in Europe and the high-income countries, it isn't as drastic as it is in the low and middle-income countries. And I'm talking particularly about Africa and Latin America. I think it's particularly, they have been so overworked and so overstretched and doing 2 shifts at a time. It's not safe for them. Many of them have gone out sick. So when you lose 1 or 2 from a shift or a ward, you know, that puts a huge burden on the other people who are already short. It has been extremely difficult. It has been extremely difficult with the very sick patients, as has been already said, in intensive care. And, you know, bringing in other nurses to cope with the demand, even with specialized areas. that makes it difficult for the nurses that are already there, because you don't learn the specialist treatment, you know, in any one day. It takes a period of time. It takes a year to longer to look after these very ill patients. Added to that, and has already been said, working so closely with the patients and working so closely with patients that are dying is extremely stressful. You cannot imagine how stressful it is, and particularly because families haven't been allowed visit. So what you're trying to do is you're trying to treat the patients, but you're also trying to be their communication between themselves and their relatives, and you're trying, this is so traumatic for anybody, and that's what we've heard back from all our nurses, that they're extremely stressed from all of this, and that there is no great support, particularly counselling support, occupational health, as has already been said, which is very much needed. If you want people to continue actually looking after people in these conditions, they have to have some support. Otherwise, they themselves will go out sick. There is no doubt in my mind about that. It varies so much from country to country. It's very hard, but I can safely say that in all countries, there is a shortage, and particularly when nurses have gone out. So many nurses have gone sick. So many nurses, as I said, have become ill with the virus. And even if they haven't, if they've tested positive, they have to still be out of the system for a period of time. So you take a couple of thousand nurses out of a system in any country. That means that the rest of the nurses are extremely overstretched. The only other thing that I would say is that for the people who have not wanted to come to the service because they're afraid, or the people who need screening or need testing, I think I worry about those in the future. I know nurses, certainly in advanced practitioner roles, have tried to reach out to them, have tried to follow some of their cohort of patients as to the community if they haven't been coming, and they have tried to create different initiatives to do that. And we've heard about those, around the world, but those need to be evaluated and rolled out. That's all I would say.
Çok teşekkürler.
Thank you very much. Alexis, is there anything that you would like to add?
Yes. Teşekkürler. First of all, I want to say, speaking about nurses, that in Greece we have this peculiar situation. We have the lower number of nurses per population and one of the higher number of physicians per population. So it's a very, doctor-centered system, which means very also difficult to manage. Huh? As for the nurses, you are right. And in Greece, because exactly we don't have nurses, but we have also the traditional, culture of family and so on. A lot of work in the hospitals before COVID was done by the informal carers, which were the family, So now there is no informal carer, and all this burden is on the shoulders of the nurses. And we have, as you said, yes, I agree, the problem that our nurses are really extinguished. I mean, they are burnouts and so on and so on. So as for the allocation, and this is a very important issue, I think, and I don't know what's happening to other countries. In Greece, the government is taking people, professionals, nurses and physicians from primary healthcare centers and sending them to the hospitals in order to help dealing with the cases of COVID. And this is also another tragic experience, because in our view, they had to do the opposite. I mean, to enhance primary care in order to keep at least the mild cases at home and serving them and caring them at home, instead of putting all the morbidity in the hospitals. And this is also a very important issue. Here, I have to say also that in the first a year ago, actually, the first months, 2 or 3 months of the epidemic in Greece, we had this problem that there was no primary care in terms that the public primary care services were saying, we don't know about COVID. The private physicians under the association, again, they closed down their surgeries. So there was not at all any kind of primary and specialist also care in the community. So all this was shifted to the hospitals. And of course, they found close the doors if you are not COVID. So the non-COVID, as I said before, was out of any service. So yes, it is a very important issue. We are pressing, here we have fortunately, we have the union of doctors working in the hospitals, in the public hospitals. So it's a specific union of physicians working in the public hospitals. Is very active and very radical, and they are trying and they're pressing the government to open new vacancies, to open new people working there and so on. Because really the problem is, and as it was said just now, as we are going in the third wave, which is very strong, we are afraid to see even worse situations than in Bergamo last year in Italy. Thanks.
Çok teşekkürler. Owen, siz...
Thank you very much. Owen, you are the Deputy Secretary General of the Confederation of Trade Unions. Is there any complaints that you have received from the healthcare workers? Did you have any problems? Do you have any information on this topic?
Yeah, definitely, and I endorse what my colleagues on the panel have said. There have indeed been the main problem has not been where you allocate doctors and nurses. The main problem has been where you allocate the resources of the government and the resources of our society, which have not been put into the health service. So in any country. So those countries which have suffered austerity have seen enormous shortages of doctors and nurses, especially, as Annette says, where people are off sick or isolating. And those countries, like those in Africa and Latin America that she mentioned, which never had the money in the first place, let alone to have it taken away, have also suffered terribly. In the UK, as Annette will know, the government did put some money into establishing a whole network of new hospitals to deal with the increased number of patients, actually called, since she mentioned Florence Nightingale, called Nightingale hospitals, and hardly any of them have been able to function because the government didn't have enough nurses to actually staff them. And that caused enormous, it was a pointless exercise. As Annette said earlier in the conversation, there must be no return to austerity as a result of the costs of the pandemic. We need to put resilience first, not austerity, when it comes to coming out of the pandemic. And the British government's decision to replace the regular applause for nurses that happened during the first part of the pandemic. Every Thursday night, we would go out and applaud the nurses and doctors who were working for us so hard. That's been replaced by a derisory pay offer for nurses this year, which is causing real anger among both the medical staff and also their patients and potential patients, like the ordinary citizens.
Çok teşekkürler. Özlem.
Thank you very much. Özlem, would you have any contribution to make here?
Peki.
Okay, thank you.
Şimdi bir soru alıyoruz gene.
I think we can take one more question, and this is to Dr. Montgomery. Maybe I can say a few things. I do agree with all that has been said, but the first thing that comes to my mind is
Bu olan bütün olumsuz çalışma koşullarının sağlık
All
çalışan
these negative conditions that have been subjected to the healthcare workers, the heavy conditions, the workload, and the fact that their illnesses were failed to notice to the World Health Organization, the responsible party are never the healthcare workers here.
Dolayısıyla sağlık çalışanlarının ve
Thus, the healthcare workers and their organizations actually should target the real people responsible behind these bad policies. And I think we can only overcome the future pandemics if we do this. And of course, the responsible party is the neoliberal health policies. Thank you very much for your contribution. And we have actually the last 10 minutes, but we need to give a break because we have the second session at 8 p.m. And this is going to be a meeting of the trade unions of the healthcare sectors and associations from Turkey. We have a lot of questions about this particular session. We will be really glad if you can stay with us because we can have further questions after the second session. I would like to thank all the participants, the panelists. The comments are really good. We have a lot of people who are watching this broadcast, both from our country and from abroad. We really had good opinions. Thank you very much for your contributions.